Welcome, everyone. I'm Dick Deming. I'm Medical Director of MercyOne Cancer Center and the founder of Above and Beyond Cancer. Welcome to our weekly cancer education series. It's brought to you in part by a grant from the Iowa Oncology Society. And tonight we're going to talk about dry needling. And we have with us two doctors of physical therapy, Samantha McShane and Staci Larsen. Welcome, Samantha and Staci.
Thanks for having us.
So before we talk about dry needling, let's get to know you a little bit. So Samantha, let's start with you. Where are you from originally?
Mostly Johnston area. Kind of grew up all over the Midwest and then landed in Johnston, did middle school, high school there.
And high school at Johnston High School.
Johnston High School, yep.
And what was your claim to fame at Johnston High School?
I was the state champs in volleyball.
Awesome.
So that would be in my junior year and then runner up my senior year.
And were you a hitter, a setter?
I was back. I'm 5'6", so I was back row for sure. Defensive specialist.
Good.
Yeah.
But state champion.
Yeah, we were state champs
Very
in
good.
08. It would have been.
Okay. And Staci, where did you grow up?
For the most part, Waukee.
Okay.
And settled there from elementary school on.
And high school back when there was only one.
When there was
Waukee High
one, some
School.
more cornfields around the area.
Yeah.
Yep.
How many in your high school class?
There was about 350.
Okay, so it was still a big school.
It still was, yeah.
And what was your claim to fame in high school?
I would say basketball had a handful of records.
Awesome.
So I think maybe still one holding on, but
Shooting, rebounds, assists,
it was assist and shooting and points.
triples, double doubles. I mean, double
Um,
doubles.
yeah, double doubles.
Who gets triple
Double doubles, that would be impressive. No, some double doubles, but
Good.
yeah,
Okay,
no
good.
records for that one.
Good. And then, where did you two meet?
We met at physical therapy school.
Yep.
Actually,
Okay.
we were in the same class at Des Moines University. Graduated together in 2016,
Great.
and then we've actually worked together for Mercy since then.
Yes, and
Yeah.
so we're part of the same family. We're all,
Yes, we sure
all
are.
part of MercyOne.
Mhm.
Explain a little bit about what's the education to become a physical therapist. And now everyone who graduates with physical therapy is a doctor of physical
Mhm,
therapy,
mhm.
similar to pharmacists. Now we're all doctors of pharmacy. And
Right.
Mhm.
so do you get an undergraduate degree first before you get into physical therapy school? And if so, maybe Samantha, where did you get your undergraduate
Yes,
degree
yep.
and what was it in?
So you start with an undergraduate degree, and all the schools have certain prerequisites. And so as long as you cover those prerequisites, then you are free to apply to the different physical therapy schools. So a lot of them will have track programs. So I went to Iowa State and graduated with my bachelor's of kinesiology,
Okay.
and then a minor in psychology. And then you do 3 years of physical therapy school after that. So
Okay.
then that's how you end up with your doctorate degree.
Okay.
Yeah.
And Staci, where'd you get your undergraduate degree?
I went to University of Evansville in Indiana,
Okay.
and then got my bachelor's of exercise science, and then went on to DMU.
Okay. So it sounds like in undergrad, you kind of were tailoring your program to
Mhm.
be
Absolutely.
to make you a strong applicant for physical therapy school.
Yeah.
Yes.
There's
yeah.
definitely different program. I mean, you can kind of do whatever, but as long as you have those prerequisites. But there's certain
Mhm.
programs that make it a little bit easier track or more similar.
Yeah.
Mhm.
So
to the
you're
studies.
both athletes and
Mhm.
both studied in college things related to the physical body and performance.
Mhm.
So Staci, when do you think you first thought of physical therapy as a profession?
I have a very specific moment that I knew. My 8th grade year, I was playing softball. I slid into second base, fractured my thumb. Got around to third base, and he's a surgeon with Mercy, and he's like, "Oh yeah, we need to take you in." So took me in for X-ray, surgery. Ended up in physical therapy, and I knew I wanted to do medical field, but at that moment, I was like, I love this setting
Right.
and what they did for me because I loved sports and got me back to it.
So it was a broken thumb
It was a
that
broken
led
thumb.
to
Yes.
physical therapy.
It was my own injury.
Okay.
Yeah.
And what about you, Samantha?
It took a little bit more discovering what I wanted to do. I was actually originally in construction engineering at Iowa State, and I did well in the classes, but I just couldn't see myself doing that for the rest of my life. So I did like career counseling. I did some job shadowing, and I was interested maybe in chiropractic, maybe in massage therapy, maybe in health and fitness management. I was telling my dad about it. I also remember specifically at Thanksgiving. And he's like, oh, this sounds kind of like if you would combine all of those things. You have physical therapy, which I'm going to right now. Let me talk to my physical therapist and see if you can come shadow. So I went and shadowed her, and I said, this is it. This is what I want to do. So I switched. I think it was at the halfway through my sophomore year of college.
Okay.
And been on that track since.
And then maybe describe a little bit what the physical therapy school, going to DMU and getting the physical therapy degree, what does it, as in medical school, the traditional way was the first 2 years were all books and classrooms, and the second 2 years were clinical experience. How does it work for getting a physical therapy degree?
It's a little bit more integrated. So you do a little over a year. This is at least at DMU, and it's mostly similar, I think, at other programs. But we did a little over a year of didactic work, and then you do your first clinical rotation, and that had to be outpatient orthopedic. So where we actually work, that setting we work in now. And then go back and do another didactic section, and then you could kind of branch off into either your interests or really, if you wanted to travel, did one more internship and then one more didactic session and then 2 more internships. So it ends up being a 3-year program with a little back and forth between the two, which was quite nice, just for you could go in and directly apply what you just learned in the school.
And Staci, which clinical rotations did you do while you were in physical therapy school?
Yeah, I focused more on the outpatient, kind of knew that's what I enjoyed most and wanted to go into maybe a more sports medicine side. But I was actually when it was a healthy fitness center, I was here and did a little bit of kind of the neuro side of things, plus outpatient. It's at Mercy South, which is kind of when I really enjoyed the Mercy experience and knew I wanted to kind of stick around there. I was in an inpatient rehab in Bethesda, Minnesota. So yeah.
Okay.
Kind of all over.
And what about you, Samantha?
I actually went to Washington, the state of Washington, for my first internship. It was also outpatient orthopedic, like I mentioned, and I loved that because we worked 4 10-hour days and then had the weekends to explore. So I had really great internship experience as well as some supplemental stuff. I was out there with another student, and then downtown Mercy for my inpatient, and then I lived up in Ames at the time and did one at Iowa State, my alma mater, so that was fun. And then at Boone County Hospital, similar to Staci, I knew I wanted to get into outpatient orthopedic, so I focused mostly in that field for my internships.
And the one at Iowa State, was that athletics?
It was not athletics, it was more students. So
Okay.
not student athletes, but more just students. We saw a couple athletes. I remember some cheerleaders and maybe one wrestler. And but it was really fun because they're young and little whippersnappers,
Motivated.
ready to get better.
So we're going to talk about dry needling.
Mhm.
And so I guess the first question is, what is dry needling? And then how would you compare and contrast dry needling to acupuncture?
So dry needling is the use of a small needle. It's solid and very little. That's about the only similarity with acupuncture is the needle itself. And
Do you have a needle right now?
we
You can
do,
show
yes,
us.
yeah,
Yes, I saw them there. So
yeah.
Should we take it
Let's-
out of the pack so you
Yeah,
can
Yeah,
really
maybe
explore
see.
that?
how
did
tiny
you say
it is.
little? And so I think
This is a
lit-
medium-sized length, but I'm not even sure the camera will be able to
but
see
very,
how thin
very
it is.
thin. So the diameter
if you
is
can
very,
kinda
very
see.
small.
Yes,
Gotcha.
which is an advantage from like a
Piece of paper in the
pain
background, does that
perspective.
help? Right? Not really.
Kind of, you can sort of see it.
Yeah. Yeah.
It's
So
really,
it's very
really thin.
thin.
Very
Yes.
thin.
It's almost like a strand of your hair.
Yeah.
You know.
It's quite thin, yes.
So they can be
Very-
longer, but they're all,
Mhm.
would you say they're all the same diameter?
within 0.05 millimeters. So
Okay.
yes, essentially the same. But it's used to reset muscular tissue. So that's a very broad terminology. But if it's tight tissue, it can work to reset it into a more lengthened state. If it's weak or not recruiting well, it can also improve that. So the visual I usually give people is your muscles fire like this. They've got little feet on them and they fire. If it's tight, it can't grab right. If it's weak, it can't grab right. Needling resets it to this so that it can function better, more comfortably, more efficiently. We'll go into the benefits of all the different benefits, but it's pretty remarkable.
But the way that it works is the tip of the needle goes into the muscle.
Yes.
Yes, not just in the skin. It goes through the skin
Right.
and into the
And
muscle.
that's probably the biggest difference to acupuncture, I would say. I've never had acupuncture, so I can't say definitively, but you want to grab the 100 millimeter ones?
Yeah.
So we can go pretty deep into the tissue. This is the size of the needle on this one here. But the other one was about 60 down here.
Yeah.
So like, depending on the anatomy, we can go pretty deep, like into your glutes, or it would be a spot, or hamstrings and quads, depending on the size of the body. But
and you're doing this without X-ray guidance.
correct.
Really skilled
So,
palpation.
I mean,
Yes.
you get a needle like this. You wouldn't want to do an abs with
Well,
a
you
needle
can't.
like this,
You can't.
but you would want to be careful.
You'd want to
right?
be careful. Yes.
So I guess my question is, how do you make sure, since you're not doing this under ultrasound guidance or X-ray guidance or fluoroscopic guidance, how do you know it's in the right muscle? So let's go with the glutes, where you're not going to run into anything.
The glutes
too
are
bad.
easy.
Yeah.
Yeah.
You could
'cause
possibly hit the sciatic nerve or a major blood vessel, but how do you know you're in the correct muscle?
the glutes, you actually hit a bony backdrop. So you can go
All the
until
way to
you
the bone.
all the way till you hit it. So
Mhm.
Which sounds scarier than
And
it is.
yes.
Sounds like that sounds weird.
Uh-huh.
And I think even you can maybe attest in the
Yeah.
class, we're like, are you sure? Are you sure we're supposed to be able to touching the bone? But now I think I would almost prefer that in a location, because I
Then
have
you
a
know.
very definitive
Right.
endpoint.
Yeah.
And most patients are shocked by how they don't
Little
feel.
discomfort there
And
is,
yeah, they do not
because
feel
the
long
needle
needle.
is so
Yeah.
Yep.
it's not the length that
Mm-mm.
matters, it's the
It's the
Thickness of
location and
thickness
yeah.
of the needle in terms of pain.
And we've
Yes.
literally had patients say, "Is the needle in?" And I know that sounds shocking, but some of them
Yeah.
don't even realize it's in the
Right,
tissue
and it's
quite
in
yet.
3 inches. and-
Right.
Yeah, they have no clue.
Okay.
Yeah, and a lot of training. So
Yep.
in physical therapy school, you do, very intensive and anatomical education. We do cadaver dissection, so you see every little thing that you are going to ever place your hands on, which is wonderful. It's incredibly educational. But when you go to a dry needling class, I think the biggest thing other than like the technique, is probably your palpatory skills, or your ability to feel with your hands, because that is your biggest indicator as to where to go in the tissue, other than just your knowledge of anatomy. You have all your points of reference, bony landmarks, that kind of thing, and then you use your hands, and the class is all about, okay, where are you trying to go, what do you want to avoid, and how do you do that? And so
Mhm.
you do a incredibly intensive training. Probably, I would say maybe the most intense continuing education
Oh, absolutely.
that we've
Right.
had,
Because
because you're
anatomically
using
so important.
correct.
And,
Yeah.
and you
right.
mentioned 2 things, and it reminds me of radiation therapy. What do you want to hit
Mhm.
with the radiation beam, and what do you want to avoid?
Right.
And those were 2 things you mentioned too.
Mhm.
What is it? Where do I want the needle to go? What do I want to make sure I don't
Yes. Yeah.
hit?
And we have collectively probably done this over 10,000 times, I would say, each of us. So it's, and had never had any issues with
what
Knock
organs?
on wood.
Yeah, I know.
What theoretically, what
Yeah.
organs or structures are you most concerned about? The things you want to avoid. I mean, I would assume great big nerves, like the sciatic nerve.
That's
Mhm.
my
I would assume maybe a great big blood vessel, like the
Yeah.
femoral artery.
Yep.
Other
I would say that the 2 that come to mind are our SCM. You're going to obviously be
yeah.
at
So
risk
if
of some of
if
those,
you're doing this sternocleidomastoid muscle in
which
the neck,
right, you're staying away from definitely the veins, arteries there.
Mhm.
But I mean, they're pretty visible in a lot of people, and you can stay below them. And Sam
Mhm.
does the SCM, so
Mhm.
she can attest more to
Yes.
that. But then the glute, the piriform is specifically the sciatic nerve is
Mhm.
you just stay kind of lateral, medial.
Uh-huh.
I
to
would
its
say
course.
generally arteries and
Yeah.
veins and nerves are the things you're really trying to
Right.
avoid, because those structures dive through muscles. And so again, going back to that cadaver dissection, years back when we were in PT school. But remembering, what that looked like and having like this 3D image of in your brain of, okay, I know where this muscle lies, the origin and the insertion, and where the sciatic nerve is going to dive through, and how do I avoid that?
Right. And then of course there can be aberrant paths. So
Sure.
Not everybody's anatomy is exactly the same place the textbook says it should be.
Yeah.
So if you were to hit the sciatic nerve with the patient, would you get a reflex? Would you get a little tremor?
There'd be a
or
zing.
jerk?
Yeah.
Like they would get that.
Get a little zing.
That's the interesting thing is it's not obviously would not be comfortable for that to happen, but unless you like sat and repetitively did that, which no one would do that, you really nothing really happens.
Injury.
And they kind of go through that in the course too. When you're introducing the needle into the soft tissue area, you're kind of doing a smooth glide into it first. So if there were some type of response, whether that's kind of like a nerve-like reaction or a really sharp pain, which may indicate some blood vessels, usually superficial blood vessels, you can always change the course of that needle too. So we're kind of feeling out the response before we would potentially kind of piston into that tissue. So usually it's pretty, and it's such a small needle too, even if we run into some superficial blood vessels, which would get a little bit of bleeding, it's not damaging.
And in the world of, doing biopsies of tumors, I mean, interventional radiologists, but they do it under the direction of some radiology guy. But you can poke a needle through a lot of tissue without causing any significant damage, even blood vessels and lungs and other organs that you probably don't get close to.
Exactly. Yeah.
Right.
The with certain levels of certification, you can do different parts of the body, and so I'm able to do the thoracic spine, and that is those are over your lungs, your ribs over your lungs. So that is the one area that you are just extra, I would say, the most cautious with. But I remember very specifically in the class, these people that taught us are like dry needling wizards and have done it for years, and that's like their entire business. And they have heard of one instance, and it was someone who was doing it out here, which you're not supposed to do. And that was the only
one instance of a pneumothorax.
Yes, of a puncture of your lung.
Yeah, because actually in the world of doing biopsies, you actually do intentionally put the needle through the lungs, and even in those situations where you're intentionally putting the needle through the lung, you only get about 10% pneumothorax. But you're prepared to put a chest tube in those situations.
Right.
So let's talk about what are the indications, and let's just talk about general indications, and then we're going to talk about potentially the role of dry needling for cancer patients. But what would you say are the top 3 indications clinically that you've experienced doing this for dry needling?
If you're human and have pain, no.
Kind of.
Yeah, I know. Any type of pain. Someone comes in, they're tight, they're painful, they feel weak. I think there's really some type of benefit anyone could notice from that.
So to get more specific, I mean, somebody sprains their ankle or has a hip replacement, and are those things? I mean, I think I thought you might say like a trigger zone, like somebody's got this knot just medial to the scapula where it just is a wadded up contracted muscle.
I think that's that would be like the baseline indicator is like a trigger point tissue that you can grab onto and you're like, ooh, or like strum across it. You can have like a ropey type tissue. That would probably be the baseline indicator. As we've done this more over the last 5 years now, we've seen so many other benefits with like recruiting those muscles. So if you're watching a patient move, which is always part of, physical therapy in general, but part of dry needling is you do this assessment. And if you watch them move and you see, oh gosh, that looks like that muscle isn't firing efficiently. It's not firing when we want it to in like the gait cycle or something that might indicate it. You can kind of tease that out with a little range of motion or strength testing, and then needle it if there is dysfunction, which usually if there's indicators in your brief assessment, there is typically some type of weakness that can kind of pinpoint where to needle. and then you needle and then reassess and do better. So yes, definitely trigger points, tender points, tight muscles, but then it kind of where it gets maybe fun, and maybe patients disagree, but we think it's fun is okay, there's other ways that we can kind of use this. So that's when she jokes that if you're human, you could use dry needling, but really, like, everyone has dysfunction in some way, whether it's tightness or weakness or whatever. And so it could benefit. And then that's just when you just like weigh the pros and cons. We talk through, benefit or the risks associated with it, which are quite low, the potential benefits. It's $20. Where does that land you? And
So maybe give some examples of particular issues patients were having that you provided benefit with dry needling.
George, would you go to that table slide if you don't mind?
So we've got some slides we'll bring up here.
There we go. So I think the diagnoses over on the right is probably a good spot. So like you mentioned, the trigger points, tendinitis, tendinosis. So that would be the connection of the muscle to a bone. The itis portion is just it's acute. Tendinosis is it's more chronic. Muscle strain.
And maybe stick with that tendinitis,
Sure.
tendinosis. Which parts of the body would you... So, for example, sometimes I have patients who have a costochondritis, and that's where the ribs attach to the sternum. And that does that fit into that category of tendinitis, tendinosis, or that would be more of a arthritis?
I don't know that you would, just because of the costochondritis is between, it's like where it's within the rib.
Right, it's rib and sternum, so it's more of a joint.
Yes. Where I could see it being beneficial would be two different spots, the pec, so pec major, pec minor. They're going to come over and insert there. Maybe SCM, where it's going to come and insert right on the sternum. And then even the thoracic spine, that's going to come around the ribs, attached to the front and then attached to the back of your spine. So if you can needle back here where you have the insertion up here, that could be incredibly beneficial. So I don't know if I'd call it tendinitis, tendinosis, but similar concept.
Like IT band?
Oh yeah, IT band syndrome, plantar fasciitis. So that was mentioned before. Golfer's elbow, tennis elbow, headaches. There's quite that. So all of the, I guess not headaches, but all of the ones that I just listed are a type of tendinitis. Just have a kind
Like
of
shoulder pain, shoulder
colloquial
tendinitis.
term.
It's a big one too.
Rotator cuff tendinitis.
Yeah.
That's probably a common one people have heard of.
Okay, right. Okay,
Yeah.
and then the next one, you talk about muscle strains. And so like you tweak your hamstring.
Exactly. Yeah. Or like an overuse injury, or especially this time of year, people are getting into yard work. So they bent over and then their back grabbed up, and that's a very common way to strain muscles, or getting back into biking, back into running because it's nice out, that kind of thing. It's just like either repetitive overuse or like a overload to the tissue, and you strain that muscle. And that could be helpful. Okay.
And then chronic pain. So seems like the whole world has low back pain,
It's been great for chronic low back pain.
Yes.
I think
Yeah, specifically low back pain.
Absolutely.
And so with chronic low back pain, where would you put the needles?
Into the multifidi, so right along the lumbar spine.
So right,
usually kind of determining.
So
just
not over
right
in the
lateral.
SI area, but more right along the spine.
Yep. But often the glutes combine just because of the interaction to the SI joint and all the different fascia around that area are very beneficial to do all that together. So if we can convince a patient of more spots, then they can be really helpful.
So back to the theory of how it works, you talk about re-engaging muscles, but if you're needling fascia, do we think that there's other ways in which it works? Do we think that it stimulates blood flow to the area? Do we think maybe it gets our immune system focusing on the area? What are some of the other theories of how poking in a needle where it hurts might help with healing?
Yeah, both of those are true. Increasing blood flow, and then I'm going to say changing inflammatory markers, because some increase, some decrease in the way that you'd want them to for healing. There's been more studies in the last couple years as dry needling has gotten more popular, where they're going directly into tendons or directly into fascia and doing a lot more of the pistoning, because something we didn't mention earlier is as long as it's appropriate, we can use electrical stimulation on the needle to make that muscle fire.
So you place the needle, it remains stationary,
Mm-hmm.
and then you attach electrodes
Yes.
to
A little
it.
point
Yes,
stem there.
right. Yep, with that little machine there.
Mhm.
But obviously, if you're going to do that into tendon or fascia tissue, that is not contractile, so you wouldn't want to stimulate that. So you would just piston in and out, and that's from what I've heard, a little bit more uncomfortable than just the muscular dry needling, but they're starting to look more into that and looking at other tissues that can benefit and seeing good results from it.
Okay.
Which is great.
Let's say acute injury. So I mentioned sprained ankle. Is that something you would dry needle? My ankle is now twice the size and it's a little black and blue.
Absolutely. I mean, you can do areas around it, and Sam can do some in the foot as well, just with her level 2 certification. I think we stay away from too acute, just to allow kind of the initial healing phase and inflammatory response that goes to kind of protect that tissue initially. But again, there's areas kind of around, because you have a lot of different insertions from those just lower leg muscles that play a role. Posterior tib is a big one to help kind of stabilize and provide the extra arch support, and is crucial in ankle stability with ankle sprains after. So yes.
Okay.
Yes, but you're not going to go into the bruise, or you're
No.
not going to go into the big puffy area. You're going
Right.
to stay above it. We're going to come up
Yeah.
into the muscle belly, up into the top part of the lower leg. And same thing, like if you would like sprain your wrist, you're not going to put a needle into it, but all of these muscles that we'll actually do a little demonstration of later, all of these come down into the wrist. So if you can get all of these
Right.
firing really well, and just improve that blood flow, lymphatic flow, all that does is just help your wrist move better, move more comfortably, and promote tissue healing.
Then radiculopathy.
Mhm.
So maybe explain what you mean by radiculopathy, and then where would the needles go to help relieve radiculopathy?
So I guess what we mean by radiculopathy would be pain stemming from the spine that radiates into one of your extremities. It doesn't, I think most people are familiar with like a pinched nerve. That's similar. Which, yes, so kind of like a pinched nerve, but it doesn't have to be 100% pinched. Let's say that. So it could be just a dysfunctioning nerve. So let's say it's functioning at 70%. So similar to what Staci said before, we'd go into the multifidi. So at around the spine where that nerve starts at before it comes down into
And when
the
you
tissue.
use the word multifidi, are you talking about the paraspinal muscles, the small muscles?
Yes, very deep in right up next to the bone. So this is another spot that has a bony backdrop. You want to contact the spine. And so you go through, like most people will strum across their low back. Those are your big erector spinae muscles that you can feel. So deeper to that are your multifidi, which are little local stabilizing muscles on your spine. And they help support the spine, but they also, well, this is a little deep into the weeds with the anatomy, but they're innervated by the same nerves that innervate the joints of your spine. So if you can get that muscle moving better, then the joints move better as well. And so if the joints move better, we get a lot of pressure off that nerve, and then hopefully less pressure down or less symptoms down whichever extremity, arms or legs, from the needling with radiculopathy.
And then the last one is a ligament sprain.
Yeah, that's kind of like what we said with the ankle sprain. So it's you don't go into the ligament itself, but you do the tissues above it.
So one condition you haven't mentioned that I want to ask about is peripheral neuropathy. So, and as a cancer doctor, I'm particularly interested in peripheral neuropathy that's caused by chemotherapy. So we have found that acupuncture can be helpful in peripheral neuropathy. And I'm curious whether one has ever studied dry needling as a treatment for peripheral neuropathy caused by chemotherapy.
It's not something that I'm aware of specific
Me
studies.
neither.
Can't say that I've searched real hard about it. Not something that was brought up in class about treatments or something that we've tried. My kind of theory about it is, I mean, kind of like acupuncture, if you can stimulate some blood flow and help with, help with those nerves and healing and just stimulation around it, it's maybe sounds bad to say, but why not try? Because I know a
it's
lot of
low
people
risk.
suffer from it.
And we do
long
try
terms, and-
lots of stuff
Yeah.
for peripheral neuropathy,
Oh, I'm sure.
from medicines that are kind of anti-seizure medicines to see if that works, from acupuncture, reflexology, massage, electrical stimulation, capsaicin creams, and to cause a sort of a heating effect, anything to make the nerves get feel other interactions, other
Yeah.
sort of overwhelm them, so that your brain maybe doesn't perceive the pain, it's perceiving those other sensations.
Yeah, and that makes me I would theorize that if anything, it would help because of the benefits we talked about earlier, improving the blood flow, improving lymphatic flow, and improving neural input to that tissue, and improving the inflammatory markers. All of that, I can only imagine helping peripheral neuropathy. I've not seen any studies. I imagine they're coming down the line, just as especially.
I'm going to ask us about cancer, but before we do that, let's talk about risks and contraindications. And then we'll get a little bit more specific about some conditions with cancer patients that may or may not benefit from dry needling. So what would you say are the risks, and related to the risks, what are the contraindications for doing dry needling?
Let's chart for this one too.
Sure.
Yeah,
Yeah,
might
George,
be.
there's a good chart or slide with the contraindications listed, maybe like slide 9. Yeah, perfect.
Yeah.
So this goes through what's listed, and oddly enough, the first ones listed on both sides are going to be related to cancer. So I think clinically, what Staci and I have both seen is when someone is an active cancer patient, we call their physician and we just say, hey, we'd like to do needling, or we have them call, whichever, and say, we'd like to do dry needling. Is this okay? And I don't think we've ever had anyone say no. It's almost like a liability thing. Same thing with first trimester of pregnancy. I personally, actually, both of us have been needled during our first trimesters of pregnancy, and we hadn't had any issues with that, but it's like a liability thing. If something would happen afterwards, and then they come back and say, oh, well, I caught dry needling, we've at least covered our bases. Like, well, we've got it cleared. It's not likely that it's from this, but so it's just something we like to be extra cautious about.
So with the cancer, I mean, it would be it would seem obvious that you wouldn't want to dry needle through a tumor, but that if somebody has, a cancer in their tonsil and pulled a hamstring, it's hard to imagine how dry needling the hamstring in someone who has cancer that they're being treated for in another part of the body would be a contraindication.
Exactly. I think the worry is the immune system. You just have a depleted immune system. And so anytime you're introducing anything internally, there is inherently a risk of infection. The needles are sterile and we alcohol the area. So we keep things very clean, but just because of that, we have to be extra careful.
So then the ones that are, true contraindications. So uncontrolled anticoagulant usage. What does that mean?
I think I would mean like you're in the hospital and you're like, I'm not entirely sure, to be very frank with you. You bleed like if you bump into something. Then I don't know.
But I would say that word is a modifier, so that you're not concerned if somebody's on Eliquis. You're not concerned they're going to bleed to death from your tiny needles.
No.
So
I just tell them to bleed more.
If they have if they're taking Eliquis, you still would do it.
Yeah.
Or
Yep.
Coumadin or an anticoagulant.
Yeah.
That's one of the things on our consent forms that just to make us aware of so we can have that discussion that they'll mark
Okay.
yes or no to.
And then obviously you wouldn't dry needle through an infection.
Yep.
So what about the cardiac pacemaker?
That comes back to the stim unit.
So you wouldn't want to do the electrical
right.
stimulation.
That I would say if
Uh-huh.
the biggest a hard contraindication is if you've got a pacemaker, we will not use stimulation. But you don't have to.
But
use
you don't have
stimulation.
any problem doing dry
Oh
needling
no
with
no
somebody.
no no. We just
Okay.
can't use stim.
So those, and then the precautions are
Mhm.
even, just less severe osteoporosis. How does that?
That's with
factor
that
in?
bony backdrop. Sometimes it's like in the scapula specifically with osteoporosis, you just get thinning of your bone. And so if you're going to introduce a needle into that, if you have thinned so much that you have a hole in your bone or have incredibly brittle tissue that is a thin needle would, you probably wouldn't be needling this patient anyways. They probably wouldn't be coming
Okay.
to outpatient orthopedic, I would say. PT.
So then let's talk about cancer patients. So one question I might have is, let's say a woman doesn't have active cancer. She's been cured of breast cancer, but has lingering lymphedema. And she happens to have a rotator cuff problem related to an injury unrelated to the lymphedema, but now she has a rotator cuff in an arm with lymphedema. Is that an issue?
It's something I just would clear with the doctor on their comfort with it. I have treated and am treating patients that have had breast cancer and have more of a struggle with controlling their lymphedema, and just out of, again, extra precaution have stayed away from it personally. But Sam was kind of looking through too, and seems to be more research coming out about even with lymph node removal, how that can actually potentially help lymphedema and improve kind of circulation. So I think it's something, again, to get cleared from the doctor and worth experimenting
Right.
in. Or not
Probably
experimenting,
there's this
including.
overabundance of precaution though,
Exactly.
about doing something. So probably would wait till some papers are published demonstrating.
And
benefits.
they're starting to be. There's a one I just saw while creating this PowerPoint that there was the improvement in lymphatic flow. I didn't get into the details, but that was like the summary of improved lymphatic flow via dry needling in post breast cancer patients. That was very interesting. I have a specific patient pops into my mind who had breast cancer and was cured from that, but had a lot of tightness in like through her axilla region here. And so because of her then limited motion of her arm, then had shoulder problems. So had a true musculoskeletal problem, probably secondary to the treatment that she had received, and did very well with dry needling. Got these muscles feeling better, and then actually improved some of the muscles down here that were limiting her overhead motion. So incredibly beneficial.
And obviously, don't know exactly what the patient had, but radiation can cause fibrosis of muscles and tendons and ligaments. And so we see as a late side effect of radiation. So for example, head and neck radiation, where your sternocleidomastoid just gets really rock hard. Have you seen benefit in trying to loosen up the muscles that are very, very tight from prior radiation treatment?
I don't know that I've specifically treated.
Yeah, I don't think I've ever done it with that very specific intention. It's been more, again, based on that assessment, based on what their issue is. I have pain here, whatever. I have pain doing this, and then I can look at the range of motion and strength and figure out where to go with the needle. We were talking about it though, because you had asked about this in our previous discussion about dry needling. As long as there is muscular tissue like left in it, it's not just a whole piece of fibrosis, I can't see how it wouldn't be incredibly beneficial to improve the blood flow to that area, and thus the function of what's left of that muscle, and hopefully some of that fibrosis that's within that tissue too.
Okay. Do either of you have examples of cancer patients? You mentioned one, but any other examples where you have used dry needling on patients that may have been related to side effects of their treatment, such as the one you mentioned, where a little bit of a frozen shoulder or loss of range of motion related to maybe surgery or radiation.
The other patient that comes to mind was they had neck pain and headaches. And again, I think if I'm remembering correctly, it was again a breast cancer patient. And the function of the shoulder is incredibly connected to the function of the neck and head.
Mhm.
And because of this treatment here, they had a lot of this tightness up through this back and side of their head and then up into the base of their skull here. So we did needling there, and that really helped.
Yeah.
Quite a bit.
In some situations with breast cancer patients, we intentionally give radiation to this supraclavicular region.
Mhm.
And so it can cause some issues with the brachial plexus, but also with
Yeah,
stiffness of the trapezius muscle.
Right.
So
I imagine
you might be,
that would be,
it could be
I think would
related.
be incredibly
perhaps.
Mhm.
beneficial. Do you have any other patients that
That's
you?
what I was trying to think of. I think I just had the one patient recovered from breast cancer.
So I know someone in the room who might be interested. Do you ever use dry needling to help in rehabbing after a joint replacement, unrelated to cancer?
Yes,
Knees, hips,
both.
shoulders?
Yeah.
All the above.
Yeah.
Wh-
After any,
what's your experience been with where it's been most beneficial?
knees and hips.
Shoul-
And
shoulder.
Gosh, the two that came to mind actually before you even said knees and hips were doing the quads and the glutes with both either a hip replacement or knee replacement. After you've had a surgery, muscles have to totally relearn how to work, and that resetting of a muscle with needling is very helpful. You said shoulder.
Shoulder. Absolutely. Yeah. Just there's a lot of dysfunction. Yeah.
Currently, so yeah.
Don't say names.
Mm-hmm.
Yeah. Just a lot
So
of
after shoulder replacement surgery.
yeah, or
Helping.
rotator cuff. Yeah.
Okay. Or even,
Surgery.
okay. Are you game for questions?
Absolutely.
We're going to open it up. So we've got a live studio audience. So they're going to get the first shot. But if you are watching us live streaming us on camera and you have a question, just put your question in the comments section and we'll get to those. But let's start off with our live studio audience. Tim.
Dr. Deming gave a good introduction for me because I'm the hip guy.
Wonderful.
How far out are you, Tim?
So I'm starting my ninth week.
So
Okay.
9 weeks
Of
ago.
a total hip replacement.
It's a total hip replacement. Okay. So the after effects I have are a lot of numbness in the area of the hip and in the quad. So my question is, would dry needling take care of the numbness of it? And if it does, how long would it take for it to feel normal again?
I think in short, yes.
Yeah.
It's very common, just from the position that they put you in for the surgery and the incision that they perform to do the hip replacement, to have numbness in the area. And typically it comes back, it just is very slow. Nerves regrow at a very slow pace. How I typically describe dry needling to people is that it can expedite healing. So it can just help improve that blood flow. If you can get the muscles around the nerves that are numb in that area, getting a little bit of blood flow to those muscles, that I don't see why, again, it certainly wouldn't hurt anything, but should help things and just help improve how you're loading through that joint and thus down the chain, the whole leg. I don't know if I have like a thought on timeline. I would say on average, we say muscles take 4 to 6 weeks to heal, but then you also want to load those muscles. And so in conjunction with dry needling, I would give probably that same time frame. It's just different because we don't know exactly why you have the numbness. Is it because of the incision? Is it because of the positioning that they put you in? Did they use a tourniquet, which is often very common around that area? And so it compressed the nerve and it just needs to get blood flow, which would be a great time to do dry needling to those muscles that the nerve goes to.
So the dry needling, I think I heard this earlier, wouldn't be exactly right into the place where it's numb. It'd be around that area. Correct.
Just depends on, for you said the quad muscle. Yep. So in those scenarios, and again, kind of through assessment too on how those muscles are firing and the kind of their strength and mobility and all that would kind of determine some of that too. But yes, very potential to do it right into the quad, where kind of around that numb area.
Mm-hmm.
And same thing with kind of the glutes.
Yeah.
Poon.
If a patient comes into your office and just want dry needling, would you do that, or would you do some physical therapy first?
We have both options. So you can come in either way. I would say most common is they come in for physical therapy and either they know about dry needling, so they ask for it, or we say, you know, after looking at you move, I think you would benefit from it. Here's what it is. Here's why it would help. But just today, in fact, I had someone who was referred by a friend who had benefits with dry needling. Her friend had, so referred her to come in and have that done. So she just came in. So you still do, like we've kind of mentioned before, you still do like a physical therapy assessment. It's briefer than a full physical therapy assessment. And then it's definitely done best in conjunction with exercise. So if I had my favorite way for you to do it, it would be come in for at least a physical therapy evaluation. So then I can give you exercises and then we could always continue either with therapy and needling or just needling and you do the therapy stuff on your own. It's kind of, you can sort of tailor it to the patient.
Thank you.
Yeah.
As you can see, I'm wearing a compression sleeve.
Mhm.
So I was told that I can't have blood pressure done on this arm or shots. So what if a patient comes in and they say this arm is hurting, but you can't, is dry needling not recommended as well? You can't do it on a person that has to wear a compression sleeve?
Is that because of lymphedema?
Yes.
Yeah.
Breast cancer.
Yeah. I think that kind of goes back to one, getting clearance from the doctor still, just because that's still being a little bit more researched with it. Clearance from the doctor, I would have no problem depending on what's, is it a shoulder dysfunction? Is that why you're having the pain? Potentially. Is that a good
Yeah.
answer?
Yeah, it's hard. It's never
But
just black and
you'd
white.
like to make sure that the
Yeah,
surgeon is given the okay.
Absolutely.
That, so
We want to benefit you the most we can. We don't want to make things worse. And in almost all scenarios, it doesn't cause any worsening. But in some scenarios like that, we just want to make sure.
I got a couple of questions having to do with sports injuries. I've had two major, almost debilitating sports injuries in my life. One when I was young, Tommy John surgery. I think I should have had it, but it was before it existed, really.
Sure.
The sore arm that pitchers have. Now, I cured it myself I quit.
right.
I
Very
would
common.
prefer to have
Mhm.
continued, but have you ever extended or continued anybody's career or something like that, dry needling in an area like that?
I'm trying to think.
you
of
have Tom Brady
specific-
calling you.
I wish.
I know.
I don't think we'd be living or working here, but
No.
I'm trying to think of specific instances. I would say in general active people do incredibly well. So if you are active, have an injury, and then you're trying to get active again, dry needling is awesome because the body is an efficiency machine. So it's going to use muscles in a way that helps avoid using the injured tissue. And then we get a lot of compensatory tightnesses, weaknesses, that kind of thing. So needling is great because we can both needle the tight tissue as well as the weak tissue. So I think of we've had soccer players, runners,
Well, and even the
baseball.
yeah.
It wasn't a pitcher, but a baseball player that I treated. I don't remember if I specifically needled them, but
and then a lot of our instructors for these courses were like the dry needling wizards, and they, live in Colorado, and they will dry needle athletes before they go and do, marathons and a ton of hiking and very active lifestyles. So using that to kind of help them achieve their goals with different athletic.
So is this a temporary relief or can it be permanent?
Definitely. I mean, the goal is to lead to more permanent. So it's not like you're just masking symptoms with medication. You're truly going and changing what's occurring in the tissue. And then the goal after that is, so needles reset the tissue, then we reinforce the changes in the tissue by going through exercises and then reload it to get you back to those kind of functional movement patterns. And so, sometimes you're dry needling a couple times throughout the course of therapy because as you're reinforcing and reloading, you still, if someone has poor posture, that doesn't change overnight. So they may still come back in a couple times still with that tension that's, causing a headache or whatnot. So you may still dry needle in conjunction, but the ultimate effect of it should be kind of accumulative to be more permanent if you keep up with the things that we're telling you to do.
Last question, patellofemoral pain syndrome, runner's knee. Have you treated that with dry needling? I actually had dry needling done one time for it. And the physical therapist was just kind of trying it, asked me if it had any effect. I couldn't really tell that it did. We discontinued it. So I wondered what your experience was with runner's knee.
I would say that's maybe one of the more common diagnoses that I would treat dry needling for in the knee, with the knee pain specifically, just because a lot of that is like chronic dysfunction through the tissue, and similar to what I said before, weaknesses and tightnesses that have developed over time. So it wouldn't be something you would probably feel better after having it done immediately. We do your pre-test, post-test, whatever. You'd feel better doing a squat, or better. You'd feel stronger if I strength tested your quad or glute. But there's a lot of really great research of doing that repetitively for 4 to 6 weeks in conjunction with exercise can change how those muscles fire, and then change how you load through the knee and reduce that runner's knee pain.
And I do think some of it too is, that's a big muscle, and there's multiple areas that can play into knee pain. The glutes are very important too. So, you could trial it once. If you go into one spot in the quad and you're like, oh, I don't know if that really helped. Well, it's worth, as long as it doesn't make it worse, it's worth trying, because there's a lot of other areas that could potentially affect that too.
Yeah. Sure.
I have a question about, when you're dry needling, around the rib cage and stuff like the fact that, the patient's normally breathing, and so that rib cage is actually moving as you're doing it. Is this something that you just try to find areas that don't move, or can you go into the moving areas and just kind of feel your way around that?
So you don't go over the ribs at all. You stay on the spine. You're right next to the spine, which does still, you get a little bit of that slight movement, but the whole time that I'm going to put a needle in, I've got hands on that tissue. And so I'm going to be moving with that tissue. The needle's going to be right on it. And then as I'm inserting, we're going, into a very small area, and a small and safe area. So it's not something that I'm ever concerned about, except for if patient's doing like really big breaths. I'll just say, just breathe normal, just relax, let your belly relax into the table. And usually that's all I need to say, and it doesn't become an issue.
And even with that, you're hitting that bony backdrop in those areas. So that it's not like I'm wondering if there's a lung or something underneath my needle tip. I know kind of what's underneath it, what tissue or what bone. So even if you take that breath, it's not like it's wiggling around that bone to get any deeper.
Right.
Kevin.
Yes, to facilitate recovery from, say, a rotator cuff surgery, would you wait a while and see how the patient's doing and say, well, that's not working so well for you, let's try dry needling, or could you start right day one and go for it?
There's some precautions that we just technically, just for the healing process, one of the muscle, because we want to allow it some healing time, and two, just to not introduce infection after a surgery. So there's typical standards that they usually want us to wait like 8 to 12 weeks to go right into the tissue that was affected. So there's potential to go around into some other areas, but right away, if you came to see me, 6 weeks post-op, 4 weeks post-op, probably wouldn't go into it right away.
Which kind of makes sense. If you think of like they've knit that muscle back together, essentially, they've sewn it back together. You don't want to then make that muscle fire differently. You want to let that tissue heal fully and then start to load it, or needle it and then load it. Just the same way you don't use that arm for a while. You keep it in your sling, or you just keep it down by your side for a little bit to let that tissue heal before you do any changes to it.
But then absolutely, after a period of time, it still is very beneficial.
Great success with it.
We have time for one more question.
If you're doing dry needling on someone, would you do it for like a couple months, once a week, or?
Depends.
The couple of times I had it done, it was twice, and then I was better.
Yeah, that's what's great about it is I would say typically if it's a chronic issue, you're probably going to do it. It'll take a little bit longer. If it's more an acute issue like that muscle strain or more that tendinitis, then you can, it would take less visits. I typically tell people on average, I do it 3 to 5 times. I don't know what you tell people number wise, but if I'm doing that in conjunction with therapy, I'm usually seeing them for that 4 to 6 week range anyways. So if it's kind of, I'm getting that needling input each time, and then we slowly want to taper off. My fun phrase is, my goal is for you to not need me. I want you to not need needling. So use me now, do your exercises, be compliant, stay active. And then hopefully, like Staci was talking about, cumulatively, it's more of that permanent, with the idea that it's a tool in your toolbox. If you do have flare-ups, like you go bag 12 bags of leaves or whatever, and your back hurts again. Okay, come in for some needling, or come in just like you would come into physical therapy again if you sort of tweaked things.
And we definitely see that population, where sometimes they'll want to come back like once a month. And that's where the dry needling only appointments come in to handy. They come in handy because patients can just pop in. They've had their experience with their physical therapy. They keep up with their exercises, but sometimes you just need a little more assist to reset that tissue again. So we definitely get that side of it too.
And as you mentioned, it's one of the many tools you do in physical therapy. And I don't know anybody who typically goes to the physical therapist once and
Exactly.
they're fixed. I mean,
Right.
typically it's part of a ongoing process.
Correct. Yep.
Well, this has been great. Very interesting. I've learned a lot
Good.
from both of you. So thank you so much for being our
Absolutely.
guest. So our guests tonight have been Samantha McShane and Staci Larsen, and they're both doctors of physical therapy, and they're at MercyOne Physical Therapy, and you guys are in the Clive
Correct.
at the
Yep.
Clock Tower
Yep.
building.
We sure are.
So you could, if you're interested in learning more, or you're interested in having a physical therapy session or dry needling, it's one of the few medical procedures where patients can refer themselves. They do not
Yes.
need
Right.
to have a doctor's referral. So you could refer yourself out there and meet with them and see if dry needling might be something that would help you.
Absolutely.
Thanks everyone for participating. If you know someone that would enjoy or learn from listening and watching this program, it will be available on demand beginning tomorrow at the MercyOne Cancer Center website and also at the Above and Beyond Cancer YouTube channel. Thanks for joining us. I hope you'll join us again next week.